Hello, welcome. My name is Scott Moseman. I'm here with my colleague and friend, Valerie Grogan, who is our dietitian, and we're set up to give you a talk today. We are still certainly aware of COVID. We are all vaccinated here, staff-wise, and following CDC guidelines, so we're in here. So you can hear me, not through a mask, I'll speak, but we've been very lucky to not have any transmission of cases on the unit, no outbreaks, and so we're certainly trying to continue that to happen. So today we're going to talk about the somewhat seemingly simple but yet very complex things of deciding when somebody has anorexia nervosa, what's an ideal body weight range. I'm going to talk a little bit today around how do you figure out like when the body is working correctly from a brain-wise, from a bone-wise, how do we sort of know? Val will give you more sort of nuts and bolts, how she works with patients, how we looked at growth curves, how we determine weight range from a practical standpoint. So to start that, what it means we have to do is I'm going to talk about state and criteria. I'll be brief. I know I give this during my neurobiology talk, so if anybody's heard me speak before, has talked about this. And the importance is that with anorexia nervosa, that state-dependent factor is really based on weight and nutrition. And so you got to know sort of what's changeable by that state-dependent factor. I'm going to talk about neurobiology from everything from a systems point of view as far as, thalamocortical circuits down to individual astrocytes, neurons, and serotonin about how that's affected by lack of nutrition. Talk about like how do we know like what kind of homeostasis signals biologically do patients give us when they sort of show us that they're where their genetics intended them to be, and then just like how does this impact treatment? How does this change the way we make decisions? Give you some practical examples of cases in which we even thought we were at ideal body weight, but it determines with how we wanted function to go that we weren't, and we had to make some changes. So that being said, this is my slide. So again, remembering these are neurodevelopmental genetic illnesses that happen. So you've got to have a brain that has a risk for anorexia nervosa. We're talking about anorexia nervosa at this point. So you have a trait, usually for our patients, we'll talk about what those are. Those combine with some environmental factors, and they create this cycle of illness, the state-dependent factors. And for anorexia nervosa, nutrition and how it impacts the brain and central nervous system is a central component of what keeps them stuck in their illness and makes it harder to get them better. Obviously, as practitioners, our job to get them weight restored and better is our goal. So what we do to look at these studies is, so when we look at, okay, what kind of underlying criteria put somebody at risk for having anorexia? And these things can still be impacted by nutrition, but these are things that existed before the patient went on their first diet. So one is negative emotionality and low self-esteem. And I cannot overestimate how powerful this is as far as they view the world as a risky place. They want to be safe. They don't think well of themselves. That translates out to their body. It translates out to trying to control their body as a mechanism to try to help their anxiety. So low self-esteem really underlies things. It's also something I think with practitioners that they tend, and parents, that they tend to want to be able to change. And I think we can modulate it some, but most of my patients who are very well and doing great right now would say their recovery is worthwhile. I still think if I asked them to rate things about themselves, and then I asked people around them to rate those things about them, they still probably rate themselves lower than those people around them. That this is probably somewhat genetically mediated and somewhat permanent over time, though it can sort of modulate not to be in the way so much. Perfectionism, things being right, related to their anxiety, right? And when they get anxious, they tend to inhibit or pull back or do less. They tend to have picky eating issues. This can be important in the fact that their reward systems tend to be just not done to get the same sort of rewards. So oftentimes, drugs, sex, rock and roll, those kinds of things, which normally teenagers and young adults will tend to go towards, and we got to kind of tend to modulate, tend not to be an issue for these patients, but also because they don't get reward, they don't miss a reward from food. Reward in behavioral systems tends to not motivate them or change their behaviors as much. And so understanding about them is important. Altered interoceptive awareness. So this is something at the Brain Institute that we study a lot, which is this connection of the body and the brain. And I'll go into more detail about how maybe that works for nutrition in future slides. Obsessive compulsive traits. Again, with the reward, they feel like reward is going to make a difference, but it usually doesn't. And their reaction to anxiety and stress is to pull back and to avoid. And then we also see this in family systems too. So it does make our work with this patient population about making them do things that make them feel uncomfortable, and then make the family address issues that make them feel uncomfortable is important, but certainly one of the more difficult aspects. So the way this interacts with the environment, the way that genetics works, this is a really great example from a major depressive study. And to simplify this, this has to do with serotonin as well, which we'll talk about. But basically, at baseline, without crappy things happening in your life, there's some probably underlying genetic predisposition for 9 or 10% of people to have depression risk. But what happens is, as you have significant stressors, things that are meant to sort of get the brain up and running, here we can see in people with this serotonin short arm, as opposed to the long arm, that these people that are the red triangles tend to have more stress resilient brains, so that if things happen, trauma, other kinds of things, they're less likely to respond to that with severe anxiety and then resulting depression. Those people on the shorter end of the spectrum, at least as far as their promoter region, their chance of depression with 4 difficult things happening can be 40%, almost more than twice as much as those with stress resilient brain. So important. This is really how I look at this population, even in eating disorders, is that when puberty, stress, death, trauma happens, their brains respond, and then the eating symptoms become a way in which they try to sort of modulate and deal with that brain stress resiliency. So this takes us to, okay, so once I have an anorexic patient who's now underweight and struggling, why do they seem to get stuck? Why does that process, why does every study we've ever done in the history of anorexia show that better weight restoration leads to better outcomes? And the reason is that the brain, once malnourished, becomes sort of state dependent to sort of get stuck in this illness, the quicksand of getting stuck. So one way to see this is the Key study, World War II, male conscientious objectors. They starved these guys out, and they were trying to see how, when they refed them, how to not to cause refeeding syndrome, and what were the effects of malnutrition. And these, again, somewhat lower risk male volunteers got depressed, increased stomach aches and headaches, preoccupation with food, social withdrawal, isolation, decline in concentration and judgment. So they're seeing all these things, which makes it hard to make good decisions in life and hard to make good decisions around food. And that's with none of the predisposing factors that we talked about earlier, without self-esteem and other issues. So just the malnutrition alone creates issues both around food and eating, as well as around judgment and concentration. What else happens? Well, we know that people with anorexia nervosa, especially young women, but it can happen in men too with hormones, but around that pubertal time where hormones kick in for young women, there's a rapid rise and increase in depression and anxiety, probably due to estrogen and progesterone, probably more estrogen effects on brain systems, which are responsible for brain stress resiliency. So one of the things that happen is that those hormones tend to make their brain more sensitive. It's like one of those stressors we talked about earlier, which takes their brain to a less stress resilient place. So what ends up happening is that when you don't eat, you lose your period. Body fat and estrogen are related, so you lose estrogen. So there's actually some ways in which it calms your brain down, or at least numbs your brain out, providing some relief, right? So if I start to eat again, I turn on those hormones, it actually makes me feel worse. The other thing that we'll talk about is serotonin, so that in people with anorexia, they tend to have, increasing serotonergic activity and action, especially in the limbic system, the part of the brain that's responsible for emotion, the part of the brain that's responsible for upset and brain stress resiliency. And when you don't eat, you actually lower the amount of serotonin that we get through food, and actually, again, create some relief, right? The problem is that, especially in anorexic patients, when they do not eat and things go down, they get the sort of benefit of the estrogen, et cetera. But then something called corticotropin releasing hormone, they actually turn it on more full speed, and it makes them more irritable. It makes them move more. It makes them want to eat less. And then all these things become very difficult if you're trying to keep somebody still and weight restore them. So sometimes the cycle we talk about is you have restrictive eating and you get some relief from estrogen and serotonin changes. But then corticotropin kicks in, you start to get some more worsening mood, and again, it's a thought of like, well, I feel bad. The problem, self-esteem wise, must be my body. It helps a little bit not to eat, maybe because of these changes. But at a certain point, like your serotonin levels are so low and your estrogen levels are non-existent, basically, that then it just becomes more repetitive. And if I do my job, or Val and I, or the entire team, or you guys at home are doing your job, and you weight restore somebody, you actually make them feel worse. And this is what I think makes it hard. Now, not over the long term, because one would argue, though this makes things better over the short term, that the lack of nutrition, as we'll talk about, makes thinking and life and relationships and all those kinds of things very difficult because of the effect of malnutrition on the brain. And that's really sort of the central crux of what I'd like to talk about. And then the reason why we set weight ranges and try to get them to a healthy at any size, ideal body weight, not just a certain BMI, so that things can really function the way that they can genetically, and they can make better choices around how they deal with their anxiety, and trying not to use food restriction or exercise to make those things work. Right? So we'll talk about, so what happens in anorexia nervosa? So I would say, from a practical standpoint, I think the one thing that we would certainly all notice is that you have those patients where, like, oh my gosh, they were underweight and they couldn't think, and they got stuck in the gerbil wheel. They got stuck on what their weight range was, what they could eat or not eat. And it's like, in FBT circles, you're only talking to the eating disorder, not talking to the patient. And then for whatever reason, their nutrition gets to a certain point, and it's like the clouds open and you're talking to a real person. It's so much different. I feel like I always hear all the time, I feel like I have my daughter back. And so, there's that question of, from at a cellular or neurobiologic level, like, what's creating that difference? Good therapy, meds that help out with brain stress resiliency is trying to make a difference. But FBT studies and stuff would show us that, like, weight restoration, every study in anorexia shows that weight restoration is the number one leading factor to get somebody there. Probably because nutrition is such an important framework for meds to work, for therapy to work, and for other things to be able to happen, to try to find other ways to take care of their anxiety. So they did this study, and this study talks about set shifting. And this is a sort of famous thing that happens in people with anorexia, related to perfectionism and OC, obsessive compulsive personality disorder. That, like, if you change the rules on them, it really does not go well and freaks them out. So what they did is they took underweight anorexics, they took anorexics who were in weight range, who had long-term recovery, and they took people who never had anorexia, and they looked at, like, how their brain works, perceptual and motor, just how they shift. If you change the rules, how upset did it get them? How flexible were they in getting back? The worst was, I'll just make it simple. The worst was non-weight restored anorexics, followed by what was better was people with anorexia. But people that are healthy controls were still better than the anorexics, probably due to this relationship with set shifting and rules, frustration tolerance, and anxiety issues, which we think anorexia is. So the question is, too, it's not black and white, right? You don't go from underweight anorexics and this is why my brain's not working, and then when I'm recovered from anorexia, I'm not just normal, right? I still have all those trait dependent factors that put me at risk in the first place. And some of those do include anxiety and set shifting issues. Some of them might include self-esteem issues, which don't fully resolve with weight restoration, right? But that certainly are modulated with weight restoration. And so when we're trying to turn an ideal body weight and what we can change, like we're trying to change nutrition, not necessarily change their baseline genetics. So, one of the things in here is that the brain is 60% fat, right? So neurons, how they work, astrocytes, all these kinds of things are incredibly supported. 20% of our glucose stores are used by the brain because it is this factory of electricity that has to have insulation, and that insulation is fat. And so that body fat and nutrition is, both with how much glucose you're getting to it and then how that brain functions is so important. And certainly, if your brain is not properly nourished, does it change how it functions? So we're going to talk about different levels. So one is at a baseline thing, just like cortical, gray, white matter, these things you've heard around brain, what changes, right? And the thing is on cortical thinning and on astrocytes especially, and we'll talk about that. The other thing would be the brain exists as these sort of systems that work in concert like a machine together to create behaviors and outcomes, right? So I've already talked about the insula sum. So thalamocortical circuits, right? It's these circuits that are super important for body brain connection, super important for anxiety and how we perceive things, and is really important for cognitive function and how we shift and can view our world, and then visuospatial stuff, which would be important for body image. It would make sense, again, since that those things would be impacted in anorexia, but also further impacted when somebody's underweight. We'll talk about that. And then we've talked about this too. So serotonin, what's interesting is, we've talked a little bit about serotonin and limbic systems, but there's actually some relatively recent imaging studies which sort of take things in a little more depth about the reasoning for the importance of nutrition and serotonin to produce adequate outcomes, right, for therapy and for medicines to work. All right, so as you can see here, the first one is this astrocyte density. So unless you're a neurobiologist, it's going to be difficult, but astrocytes are basically, this is a key component in the gray matter, right? And this gray matter loss is known to account for like drive for thinness and body image issues, visuospatial and cognitive thinking, that stuck process. Like they already are sort of obsessive compulsive, and it just what lets them get on that gerbil wheel, not get off. So in rats, and we're all just fancy rats, right? Basically, right? What they noticed when they starved them out is they decreased astrocytes, especially if that happened rapidly, by 83%. And these astrocytes are really important for blood-brain barrier and medication function. They eliminate radical O2s, which can cause damage, and kind of like the cleaning house of the neurons. And they're also important in inflammation. And this is becoming fascinating because we're seeing a lot of neuropathology, even genomic-wide association studies in anorexia really show that this idea that inflammation might be one mechanism of action for anxiety and obsessive compulsive symptoms. It could be an interesting sort of connection there. So all those things go downhill when your brain is malnourished. The other is cortical thinning. So cortices is like the upper part of the brain that's responsible for sort of higher level thinking and our ability, especially in that frontal lobe, to be able to like see the big picture and make the right choice. Some of that, of course, changes with development as well. But, and what we see is when they're acutely ill, they can, that cortical gets thin. But as they weight restore, they can restore about 0.06 millimeters, which doesn't sound like a lot, but in terms of neurons, it is, with weight restoration. And then you see in how they reflect with subcortical structures as well, that these are just ways that the brain's definitely changing. And as you get back, it does reverse some of these things to at least get to baseline. So I'm not going to go into depth due to time and making sure I give Val her time. But the circuitry changes, right? So, I can talk dorsolateral prefrontal cortex, ACC, amygdala, parietal. Let's take them into that frontal cortex, which makes decisions. The ACC, which is sort of like in OCD, that anxiety thing that makes decisions to have behaviors or not, do I eat or not? Amygdala, which is so affected in trauma and brain stress resiliency, how freaked out do I get when my body's not doing well? And then parietal signals, which are extremely important in body image. So decision making, doing things or not, emotional based systems, visual based systems for body image. You could see how this would be extremely important in anorexia. And then we do have some evidence, though there's not a ton of evidence, that this is affected by malnutrition, making these connections even more difficult and making symptoms stronger. So the already self-esteem and body image issues tend to be worsened by malnutrition. Right, and so the evidence we have of this is that when you stately malnourished people, we see changes in these frontal, like thinking circuits, and these basal ganglia circuits, and this runs through the thalamus. So, what we know is they don't think as clearly, they don't think as well, and as a result, it's harder to make the right choices. And this does get better as they get weight restored. They'll still have some anxiety issues. There's still some stuff in this circuit, but it seems to be as they get malnourished, their already deficits in this circuit tend to worsen, right? Again, you get some initial relief with some of the changes with estrogen and serotonin, but over time, it actually creates problems that get them further stuck in their illness. So when we're talking about serotonin, normal stuff, right? If you take somebody that's underweight and I put a needle in their back and get CSF, we see less of the metabolites. So, right, we know that when you're underweight, you lose serotonin. We know that they have blended plasma responses. So anything that works on serotonin doesn't work as well when they're malnourished, like SSRIs, Prozac, Zoloft, SNRIs, Cymbalta, Prestige. But these medications just don't work as well. What else? We know that tryptophan is important for serotonergic tone. What else do we know? That in malnourished anorexics, when you do SPECT imaging, when we look at a specific receptor of serotonin 2A, which is really important for mood and anxiety, left frontal, again, frontal stuff, parietal, visual, and body image stuff, and occipital, more body image stuff, that we see decreased activity, that is just not working as well. And so, the other thing is, in a place of the cingulate, we know that this receptor activity is closely coupled with insula and functional connectivity to determine stress resiliency by inhibited amygdala response. That makes perfect sense, right? So I'll break it down. What it means is that as they get further malnourished, their brain stress resiliency, their ability to deal with disturbances actually gets worse, right? So if we put this in the view of trauma, right, it will be that if you have a patient with a history of trauma and they have this overactive system and you needing to couple their system of is this a real threat? No. How do I deal with things? Well, the more malnourished they get, the more disturbed this gets. So it actually will make trauma symptoms and connections and things worse the more malnourished they get. Now, I think they start there because it provides some numbness and things better. But over time, as we see with malnourished patients with trauma, it becomes almost impossible to do the work. Their brains just are not neurobiologically, nutritionally capable of making the connections they need to make to do EMDR, to do good CBT or DBT or ACT therapy. You got to make connections and have cognitive issues that they just don't have when they're state malnourished. Other signs that we have. So, bone density, right? So one thing that I'll say is if I have a patient who's maybe they've chronically been sort of RFID and maybe they've been overweight for a long period of time. Well, our bodies are really built within a standard deviation to exist on Earth under a certain gravity for our bones to be a certain density so that we don't break them because they're pretty necessary to walk around and do things. So, one of the things that happens is that we can sort of use bone density as a mechanism of if somebody's been underweight their entire life, maybe they've only had anorexia for a short period of time, but their bones are really behind, then maybe as you're looking at weight restoration, then you will look at going a little bit higher to hang out some more weight on their bones to make sure they're okay. The other thing you might look at is maybe you think you've gotten somebody back into recovery stuff. Like we made a guess on weight range. We think we're pretty close. We're stable. They did have, some pretty osteoporosis. And maybe they're a teenager and they're maybe putting on some bone and things are changing. Well, getting those DEXA scans and seeing like, well, are we getting back where the bones are functional and not at risk for pathologic fracture is important. What else do we see when people are malnourished with bones, right? So we know that muscle mass and mass is most important, losing hormones, IGF. And if we get them back, we should see gains of about 2 to 3% per year, depending on the things. There is some treatments, that sometimes we use for regular osteoporosis in adults. In adolescents, there's been some things with transdermal estrogen. I'm still of the phase of just because the side effects of these medications and how it works, unless they're really severe, it's just, let's get some weight on those bones. Let's get, maybe if they can do some stress resistant exercise, if they're okay, let's get them back to where we can get them functional and try to show a positive trend over time. The other thing that we sometimes look at is menstruation, right? And this is a tricky one. I'm glad they took it out of DSM criteria because people can be so different. What's good to know, but it might be that I think somebody got somebody to ideal body weight. They're clearly 18 or 19. They should be having a period. There's no other biological reason why they're not having a period. And if I get them to body weight and they stay there now for a year, 6 months to a year, and they're still not menstruating, there might be some thought of, are they where they need to be? What's important is that it can be almost 10 months out of treatment before they have their period. It can be up to 2 kilograms or 4 or 5 pounds above where their menstruation was lost. And that you have to get them sometimes close to 100% of ideal body weight before you can get them there, sometimes for multiple months before you get there. Now, you can certainly look at estradiol levels. Here's the best example that I love about this and determining ideal body weight range. I have 2 patients in the last 5 years who are now adults. I've been here almost 20 years, so now I have adult people that are adolescents and other adult patients having babies and being married. And they came in to me solidly in recovery, eating a variety of food, married, happy, but really having problems conceiving. Loving husband, stress levels are okay. Their OB-GYN said nothing was wrong, but they were having problems conceiving. And I looked at their weights and I said, you know what? If you're really motivated, let's try to put 5 or 7 pounds on and see if that makes a difference. Let's do that for 6 months. And if it doesn't make a difference, then if that's too hard to maintain, we can look at other causes. And what was funny is both of them were super motivated because they really want to have a baby to do that. They were able to gain, one of them about 4 or 5 pounds, one of them needed to gain about 7 or 8 pounds. And then within a year, they were both able to conceive, right? So for them, there wasn't this true eating disorder things, but probably because of anxiety in their stomach and fullness and intuitive issues they didn't have, they were maintaining and having periods. They were maintaining and their blood pressure and heart rate and lives were good, but they weren't at that exact ideal for their body to work at genetic function to be able to have a baby. And they were actually guessing low. So again, that importance of function and what's the goal of your body become very important as well. So one thing that's really cool is they've done, are there neurologic signs? Like, could we get a brain scan and say, hey, somebody's getting close to their ideal body weight? And so there's this right dorsal anterior cingulate volume and really anterior cingulate that's really important for decision making and anxiety. And when they looked at this right side and they looked in malnourished anorexics that correlated with lower cognitive scores, alexithymia, OCD, that seemed to be worsened as they were not weight restored, that it got better with weight restoration, and that smaller changes in that volume actually led to patients who are more likely to have relapse. So there might be these sort of brain functions to say, hey, this part of your brain is not like giving us the signals it needs, it's not the size it needs, or it's not doing the function it needs to say that like your brain's working at peak, nutritional efficiency. So what does that mean? I got like 2 minutes, and so I'll finish up. Serotonergic agents. We talked a lot about serotonin. That's why we use a lot of serotonergic agents: fluoxetine, Lexapro, citalopram, Celexa, mirtazapine, buspirone. But it's because of the anxiety circuits that serotonin works on, but they've got to be nourished enough and have serotonin systems that are working. Atypical antipsychotics. I think there's a role for very severe symptoms when people are undernourished and you just can't get them well. But we've always got to look at the phase that, like, do they work over the long term? When do you stop them when there's all this set shifting and problems? And that they can, in a significant number of individuals, cause, blood sugar and weight issues. Like, how hard is it to finally trust your weight range and then shoot 20 pounds over that because of a medicine you're on that might not be best in the long term, but was good in the short term, and you're just not sure where to stop it. So I try to be super conservative with these meds unless I'm dealing with psychosis, severe OCD, severe resistant depression that hasn't responded to things that don't affect weight, or if I'm dealing with patients who are so sick in the inpatient thing and nothing else is working, that we use this to try to get them anxiety better, to weight restore them. And then the final thing is talking about these things to patients to let them understand why you're using weight ranges and how this might work. Laura Hill and her group has a whole thing where they're talking about applying this neurobiology and how their brains work and looking at tests and outcomes for them to see, like, that things aren't working right and that they still might need to be better weight restored. I want to acknowledge my lab crew of the people that I work with that help me do research. We're doing some great research on stomach and insula and other work. And these are the references if you're interested. I thank you so much for your time and for everything. I'm going to hand off to my dear friend and colleague, Val, to talk about the nuts and bolts of how to do as a dietitian. Thank you so much.
Hi, guys. Hair check. We're good. I'm Valerie Grogan. I am the adolescent dietitian with the Laureate Eating Disorders program. I have been here since 2012. My part of the talk is looking more at nutritionally what's going on now that we kind of have a basis neurobiologically what's happening. Also looking at the different ways that we can start to think about how are we going to figure out what these weight ranges are going to be for our clients. So in more detail, again, we're going to talk about nutritional rehabilitation. We're going to talk about the effects of malnutrition just real briefly. Dr. Moseman went way in detail with all of that, so less that I have to do. We're going to define what weight range actually means in a couple different ways. And then, as I said, we're going to look at the different tools used to consider when we're looking at weight ranges. So first off, importance of nutritional rehabilitation. As Dr. Moseman pointed out, talk therapy is the most effective therapy when it comes to eating disorders, but really the main outcome is looking at what is their weight at time of discharge. This is the only data that we have to tell us recidivism rates for things. So when we look at the different eating disorder diagnoses that we most commonly see in the inpatient setting, we see anorexia nervosa, both the restricting and binge purge type, as well as atypical anorexia. We're seeing a lot more atypical anorexia, I've noticed in the past year or so. This is being malnourished or underweight as a result of inadequate caloric intake. They can also have the binge purge subtype, as we mentioned. Atypical, again, we're seeing a lot more of this. This means they're underweight for their genetic set point, not necessarily BMI-wise. Bulimia nervosa, malnourished as a result of undoing behaviors, whether that's purging, using laxatives, exercises, different cleanses, those sorts of things. Binge eating disorder, malnourished as a result of inconsistent eating patterns or really a lack of variety. And then ARFID, avoidant restrictive feeding intake disorder, again, malnourished as a result of poor variety and just really low total caloric intake. So those are, again, the main diagnoses we see, and a little bit later we'll talk about weight ranges for each one of those. So looking at the effect of malnutrition, again, I'm not going to go into the level of scientific detail that Dr. Moseman did, but we want to look at the whole person because the whole person is affected when they are malnourished. The first thing we look at is their cognitive functioning. This is kind of a little dietitian joke, but we say they have no brain glue. Now, GLU from my non-dietitian friends, GLU is the sign for glucose, and glucose is the only thing that our brains can use for energy. So when someone has a low glucose level, they don't have enough energy for their brains to run properly. They might feel really foggy or just be very confused or kind of erratic in their thinking. They don't have the glucose there to glue all of their thoughts together. We know that there are a lot of neurobiological changes that happen. Dr. Moseman hit on a lot of those. When we look at the medical aspect of the person, we know that medications aren't as effective. Dr. Moseman talked about the serotonin that is affected in malnutrition. So we know that our SSRIs, or selective serotonin reuptake inhibitors, say that 10 times fast, we know that those are not as effective because of that malnourished brain. We know that vitamin absorption is affected, especially for the fat-soluble vitamins. Again, for my non-dietitian friends, those are vitamins A, D, E, and K. That means that those vitamins can only be absorbed and used in the presence of fats. That's both fat via intake and fat in their bodies. We also know that there are lots of organ systems that are affected by malnutrition. These include the cardiac systems. If they're malnourished and their body has to get energy from somewhere, it will eat the heart muscle. So the cardiac system is affected. We see this through weird heart rates or weird blood pressures, those sorts of things. We know that hormones are affected, definitely bone health. Other organ systems would definitely be the GI system, the gastrointestinal system, the liver, the kidney, reproductive systems, etc. Now, looking at the emotional aspect of the person, I always think of that old Snickers commercial, "You're not you when you're hungry." I think one of the first things my husband learned about me is that I get very hangry. Our clients are no different. There is a lot of emotional lability that it comes from not having a well-nourished brain. This is kind of where the caveman brain takes over. Our brains are genetically designed to seek out food, and when they're not, they get really anxious. They get really scared as well, but the brain itself on the caveman level is just really anxious about not having food. So that's that evolutionary alarm system that comes into play. And lastly, the spiritual aspect of the person. Who are you? We know that when someone is malnourished, they are but a shadow of who they actually are. I always tell my clients that I work with that you are not a walking, talking eating disorder. There's a person in there. We just have to find it. So looking at the nutrition rehabilitation process, we'll say that word 10 times fast too. When we look at weight restoration goals, if weight restoration is appropriate for this client, which again we'll determine when we look at weight ranges, inpatient they can gain around 2 to 3 pounds a week, outpatient usually around a half a pound to a full pound a week. If they're underweight, not necessarily always for that person, but if they are underweight, they can easily become hypermetabolic, especially during the restricting anorexics I have found in my years here. They can lose heat easily. They get really cold. If you have clients who have lanugo, which means that excessive hair growth that usually happens on the arms and the chest area, that's all a product of losing that heat. Because of their hypermetabolic state, and you really have to up their caloric intake to compensate for that. So anywhere from 3,500 to 7,000 extra calories a week, and that's where meal planning increases can come into play. We also know that weight restoration is not just fat, despite what your clients may think and what at least 3 girls told me already this morning. Weight restoration also takes place in the form of muscle tissue being rebuilt. We talked about the cardiac muscle having to rebuild itself, the GI muscle having to rebuild itself. Bone also can be rebuilt as long as you're not past that threshold where bone loss is permanent. And definitely fluids, especially if they are restricting fluids. You can definitely affect weight just with fluids. Full weight restoration, again, is key. When we look at how we're going to set weight ranges, we need to keep in mind that full weight restoration is, again, one of the only indicators that we have of recidivism after inpatient care. So full weight restoration, very, very, very important for a lot of different reasons. Now, looking at what a weight range is, the first place that we looked was the CDC. When I looked at the CDC, all that I found was BMI. And yes, I can hear the collective groans from all of my dietitian friends over the webcam right now. BMI is a pretty not awesome way to figure out weight ranges, but this is what the CDC has defined as a weight range. So below BMI of 18.5, you are under weight range. 18.5 to 25 falls within a normal weight range. And then we go overweight, and then we have the obesity weight range. So that is how the CDC defines a weight range. Now, looking a bit more closely at our research scientific colleagues, really good definition I found was an indicator of medical stability as justification for hospitalization, to set appropriate targets, and to track progress in treatment to assess recovery. We also know that the weight range needs to be agreed on by the interdisciplinary team. Again, we want to look at the client as a whole person. That means we have to have the whole treatment team, the medical side and the therapeutic side. And with that, building on that, we want to consider state versus weight. This is where therapists also come into play when it comes to determining weight ranges. We don't want to think about a person as a number on a scale. We want to look at that person as how they're functioning. And the therapist really has a lot of insight into that. So we also want to look at how is this person functioning? What is their state? Not necessarily what is just the weight that we're seeing on the scale. But looking at the weight range as the eating disorder community, as our colleagues that we work with every day, what do they think a weight range is? I would be remiss personally if I didn't quote Leah Graves first. Leah Graves actually hired me back in 2012, so she is the reason I'm here in this field. Looking at Leah's definition, she says the predicted natural weight zone where an individual is expected to stabilize after nutritional rehabilitation when eating and exercising reasonably and maintaining remission from eating disorder behaviors. That's pretty much it in a nutshell. But looking at one of my colleagues here in Oklahoma, Christina Duty is an outpatient dietitian here in Oklahoma City. She says an estimation of an individual's weight in accordance with anthropometric data. That means looking at the physical person as well. A broad range data point, emphasis on broad, used when analyzing a person's health as a whole. Another outpatient dietitian, Karen Kaplan-Grumman, who shares a sparkling sense of humor with me, she says a reference weight range where your body functions optimally, free of dieting behaviors, normalizing of hormones and blood work, therefore reducing one's risk for any harmful health conditions. Now, if you just ask me, I'm pretty simple. I say the weight at which the body and the mind functions optionally. But what about you? What is your definition of what's appropriate when it comes to a weight range? Well, and I can tell you what a weight range is not. A weight range is not an exact science. Unfortunately, there is no just formula that's going to give us the perfect weight range. And for my stereotypical type A dietitians out there, I empathize with you. There's no formula to determine this, unfortunately. There is currently not an agreed upon scientific-based standard in the field for determining weight goals. Dr. Moseman usually says it's an art rather than a science. We also know that a weight range is not permanent across the lifespan, especially for my colleagues out there who work with the adolescent population. We know that it's a moving target. Children are expected to continue to grow. We also know that even in the adult population, weights are supposed to change over the lifetime. They're not supposed to stay stagnant. But we also know that a weight range is not to be hyper-focused on. Unfortunately, in the medical setting, this does get hyper-focused on a lot, whether it's pressure from insurance companies or pressure from your clients themselves. We know that it's not something that needs to be hyper-focused on because it's not the only aspect of the person we're trying to restore. We're trying to restore the person as a whole, not just the number on a scale. Each individual person is unique. They're not just a number. So as we look at different aspects of how we can figure out a weight range for someone, I also want you guys to keep in mind this idea of set point theory. So this is where body weight is maintained at a relatively stable level for a long period of time for those who don't take measures to control their body size. These are just people who are eaten to eat and don't exercise like crazy and don't do anything to affect their size. They just live their lives. So we determine this when one has been eating as we would describe as normally, and again, that definition might be different for different people, participating in moderate activity for about 1 year and is medically stable. So we have to hit all of those points. Typical variance, about a 0.5%. That's not a whole lot. That's pretty small. So they're staying very, very stable. Now, this can be influenced by a person's genetic metabolic weight. Again, their genetics can affect it, stress levels can affect it. If they're having a particular stressful time in their life, their weight might change to reflect that, etc. But we know that this changes when a person attempts to achieve a weight outside of their body set point range. So this is if they start a dieting or they start a new exercise regime or something like that, feedback mechanisms are activated. So this is usually when the metabolic rate drops. As soon as you start changing the way you eat or the way that you exercise, your body tends to downregulate its metabolic set point to compensate for that. Again, that's our evolutionary caveman brain taking over, and it usually returns back to normal after ramping back up again. We've seen that with our clients before, but again, it usually returns to normal with a return to stable food intake. So keep that in mind when we're looking at these different tools that we're going to use. So the tools that we're going to address specifically today are ideal body weight. We're going to look at body mass index or BMI. We're going to talk about labs and vitals, family history and genetics, the body frame method, and then the growth charts. So first off, looking at the idea of ideal body weight. So this is a formula, so I know all my dietitian friends out there are happy, but the formula that we have used in the past is called the Hamwe method. Now this was established in 1964. Just for historical reference, man landed on the moon in 1969. So we're talking like pre-Neil Armstrong here. This is a very, very, very basic formula that doctors still to this day use. We do know that it is still common to look at. I have doctors who tell me about it all the time. Now, benefits of the Hamwe method, it's pretty easy to use. You can, even if you're good at mental math, you can do that in your head. It does give you a kind of a broad indication of where to head, but definitely not a specific indication. And it does take into consideration frame size, but definitely not in a very detailed way. We do know that it doesn't take genetics into account. It requires measuring. For those who work in the eating disorder field, we know that measuring is a really slippery slope. We don't like to use measurements with our clients. That means we would have to measure their wrist to determine frame size. It's definitely not recommended for children. So for those in the adolescent population, sorry. Not useful if the individual is under 60 inches tall. And it also doesn't work for transgendered individuals. So there are a lot of drawbacks with just using the Hamwe method. Next one we'll look at is body mass index. Again, I hear your collective groans, but let's just talk about it. So first of all, it was invented in 1832 by a fellow whose last name I will not hope to pronounce, but he was a mathematician. He was looking to do a study. It was never intended to be used as a measure of health. That was adopted around 1972 by Ansel Keys, and insurance companies adopted that as a way to look at coverage for their clients. Benefits of body mass index, it's pretty easy to use. Again, it's just a formula. You have to plug numbers in and figure it out. Again, it's an insurance company standard. Insurance companies love to use this to look at continuation of care, but that's about it. There's really nothing else that's very useful for the BMI. Limitations, I tried to contain myself. I can get on a whole soapbox about it, but I'll just stick with these that I've listed. It doesn't take into account body size, shape, frame, anything like that. We know that ratios are flawed. You have to have a stable number in there, and the stable number is height, and people are not all the same height. It's also, if you look at the history of it, it's nearly 200 years old. That's pretty wild. We know that it's dangerous for the person because it creates a label, maybe a perceived standard, an ideal. We want to be normal, or we want to be under. We don't want to be over. We don't want to be obese. It's also not recommended for athletes, pregnant women, women in general, because our body fat percentages are different than men, anyone over the age of 65, children, or transgendered individuals. So you're left with, I don't know, just a handful of people. We also know that overweight, as defined by BMI, does not mean overfat, because we have to look at overall composition, frame size, genetics, etc. You can use labs and vitals. Labs and vitals can be a really good indicator of where someone's body is meant to stable out metabolically speaking. I'm not going to go over all the hormones because I'm assuming that you guys know how to read, and Dr. Moseman did go over some of those. Benefits, it definitely is individualized. This takes into account the person's genetic set point. It's easy to monitor in a hospital-based program where we can check labs and vitals every day if we needed to, and it does provide sound scientific evidence for where a person's body is meant to stabilize out. Unfortunately, it's a little bit harder to monitor on an outpatient setting. I'm assuming most outpatient providers don't take vitals and labs in their office every time you see your clients. It can be misinterpreted by medical professionals if they are not specifically trained to look for the hallmarks for eating disorders. So there can be a lot of misinformation provided to our patients. If a regular doctor just takes a look at their labs, they might give them misinformation because they don't know. And it doesn't give exact numbers when we're looking for a weight goal. You really don't know until you get there. Now, looking at family history and genetics, this one is really helpful because genes account to 70 to 80% of our weight predisposition. Ask about your client's family members. Ask about what their siblings or their parents or their great-grandparents or their aunts or their uncles. Ask what they look like. Ask where their weights are and see if you can kind of get a generic picture. Again, it's tailored to that person's unique genetic predisposition, and it's pretty useful to kind of just set a general goal. Most people in your family are around this. That's probably where you'll end up too. Limitations though, it's pretty useless if there's really no family history involved. You can just move on from there. It's also not an exact science. Again, it's more of an art for this one. Doesn't necessarily give reliable numbers because eating disorders do run in families. They're very, very heritable. So it could be that yes, mom and grandmother were both underweight their whole lives, but perhaps they suffered from eating pathology as well. It should also be used in conjunction with some of the other methods that we've discussed and not necessarily on its own, because there's a lot less scientific evidence behind that. You can look at the body frame method. I've just put the chart on here. Again, I'm not going to read it to you guys, but this is where we're looking at someone's height, looking at wrist circumference, and trying to figure out from there, is this person just generally larger framed, medium framed, or small framed? Benefits, again, it's easy to use. It's just a chart. We love a good chart. And it is inclusive of both male and females, but it again requires measuring, and that can be a really big slippery slope. It also creates a label. A lot of our clients don't like to hear the word large or medium. Can be used for males under 5'5". So again, if you're under that, sorry. It's definitely not useful in children. So again, for our adolescent population, not super, super helpful. And you really have to already be pretty close to weight restore to get an accurate measurement. But keep in mind that weight can redistribute over time. So you're going to have to measure a little bit more frequently. And again, that's a pretty slippery slope. Now, growth charts. Oh, growth charts are my favorite. Again, there's a lot of information on here. It's a series of height and weight percentile curves. I have pulled a couple from some of my own clients that we're going to look at here in just a second. It was first established in 1977 and was revised in the year 2000. So the growth charts that we have now are the most accurate ones that we have based off of the revision in 2000. It's generally recognized that it's definitely more accurate than BMI because it looks at the overall picture. It looks at both height and weight, and it looks at things from their entire lifespan. So it's really, really useful. Any population, gender, age. Now, if you don't have growth records on your client, get information from wherever you can. I literally had a dad who went to the door frame where he measured his daughter's height every year and sent me a picture of him measuring each one, and I was able to plot things for him from there. I've gotten pictures from baby books. Get whatever information that you can so you can kind of plot things on your own if you need to. Now, when you look to use that to create a weight goal, it's best to go back about 2 years before any sort of eating pathology started. So if you have a client who started overeating at age 10 and then all of a sudden developed anorexia nervosa, maybe see where they were between ages 6 to 8. So before any of their eating pathology started. Benefits, it's super unique to the individual. You can use it regardless of gender. It gives a really big picture and is generally accepted as the gold standard. Limitations, though, can be difficult to attain, especially in adult populations who didn't keep close records when they were kids. You can have data kind of scattered all over the place. You might have strong gaps in time where they just weren't going to the doctor, and you may not have enough data from before the start of their eating pathology. So you kind of have to just extrapolate. Now, looking at some of these growth records I've pulled for you guys, we see here that this person's data started around age 12, and you can see that they were pretty solidly following the 70th percentile line until they started dropping, and now they were closer to the 50th percentile line. So I've highlighted where I would shoot to get them back on their growth trajectory. This next one I pulled because it shows you that their height was affected by their malnutrition as well. This was a kid who generally was closer to the 95th percentile, but you can see as her weight started to drop, her height also leveled off. She stopped growing to where she dropped below the 50th percentile, even though earlier in life she was closer to the 90th percentile. So she definitely has some catching up to go with her growth. But you can also see where I've put those two X's. The lower X is the 50th percentile. If you're just shooting to refeed your clients to the 50th percentile, that is still below this individual's genetic ideal. That's the second X up there. Again, we have to follow the line of where they would have been had this never happened. This one, same thing. This client was around the 90th percentile, dropped to below 50th. So I would shoot to get closer back to the 95th or 90th percentile, maybe a little bit under. You can see that they kind of bopped under that line a little bit. But that's where we would want to get back to for this particular client. Again, growth records, super, super helpful. They're my preferred method for figuring out where we want someone's weight trajectory to be. This one, again, this client definitely was overweight at the start of their life. That's just normal for them. But you can see up here at the top, this is where some overeating pathology started. So we don't necessarily always want to refeed our clients back to the highest weight they've ever been. We want to look at where they would have been had this pathology never started. So rather than trying to shoot them back up here, I'm looking to get them back on a normal trajectory for them. When you're looking at adults versus adolescents, even if you're looking at growth records, consider age at onset, consider stage in puberty if you're looking at adolescents. Remember that for both populations, it's a moving target. Now here for you, I've kind of extrapolated out where we are looking for different diagnoses. These are the different things that I would recommend you use when you're looking at weight ranges. Note that it's just not one thing. It's a lot of different things. You want to take a look at all of these and kind of extrapolate out and use your colleagues. Make sure that you're working with an interdisciplinary team to work on setting that weight range to where all treatment team members agree. And here are my references. If you do have further questions, you are always more than welcome to reach out via email. We're happy to talk about anything that you would like.
We'll do over here.